Good morning. As was mentioned, I lead a lab at MIT focused on humanitarian supply chains and do a lot of work in response to international and domestic disasters. I like developing models and data and analysis and publishing papers, but I often find that some insights come through telling stories. And so I'm going to tell two stories today. One about international response and what we can learn from an international context of a role we played in international response, and then some lessons from last year's hurricane season in the U.S. How do we move the slides forward here? Is it? Oh. 3. Oh, this one. Okay. Thank you. So, as an academic, we don't often get a chance to be operational, but in 2014 and 15, I worked with a group called Excel. It was a group of medical schools who had worked in Liberia for 6 years at that time, developing training for physicians and nurses and the healthcare workforce in the country. As the Ebola crisis was growing, the people that they had trained, and they had worked with the Liberia College of Physicians and Surgeons in developing a residency program, they were getting word that there weren't supplies at the hospitals. And people were appropriately providing for the emergency treatment units, but the hospitals were not receiving the protective equipment. So they started mobilizing a Kickstarter campaign, which led to a grant from the Paul Allen Foundation to provide support for the Ministry of Health in providing supplies to those hospitals. And we at MIT, along with Avenir Analytics, provided the logistics capability to help deliver supplies that were part of this program. I will say that this was an amazing venture that involved a lot of excellent Liberian talent that we helped to train and deploy, and I feel better in their ability to respond going forward through that engagement. The problem was there had been a lot of healthcare worker deaths, and as my colleagues in these medical schools had been documenting over the years, that the workforce was already thin from lack of training due to the war. And so hospitals were undersupplied, understaffed, and they didn't have effective infection control practices in place. And as a result, in September 2014, the capital city of Monrovia had no open hospital for an entire month, because workers were not safe in the hospital setting to provide services. So a solution, working again with the Ministry of Health, at their invitation, with a host of the Liberia College of Physicians and Surgeons on the ground, we, academic institutions, helped to put together an intervention that leveraged training with the curriculum called Keep Safe, Keep Serving, developed by the Ministry of Health in collaboration with CDC and WHO. Doing a week of training with people at the different hospitals, and then training focal persons to follow up, but also marrying that with supplies. You can't effectively do training of PPE donning and doffing without having the supplies to practice. So making sure that the supplies arrived before the teams who trained arrived. We were very careful to arrive a week earlier with the supplies. And not only training the medical workers, but also water and sanitation workers. I'll highlight a few key things in mobilizing that kind of supply chain that I think are important. The first is we began our initiative with a one-day kickoff with the program and the supply chain leaders. So the medical doctor who was designing this from the Boston Children's Hospital had worked in these hospitals in Liberia for 6 years, knew the practices, knew how people operated, could articulate where needs for PPE would arise, how often, how it would be utilized in the facility to help really understand the true demand at that facility. That was then married with the ability to procure supplies and meet those needs. And we articulated at the beginning a very clear plan of action, a demand plan and a supply plan that we had clear assumptions, goals, and we would update that as new information came out during the response. So having a clear demand plan and supply plan, I think, was an essential part of the ability to respond. It's also something that, as was mentioned earlier, sharing information is important. We shared this information with others so they could know what we were doing so they could respond appropriately. One of the challenges in mobilizing was the specifications of PPE. There are various products needed to provide that kind of protection, a combination of products, many of them mentioned earlier this morning. And also there's different standards as to what is an appropriate product to meet the needs. There's US standards, ASTM, there's ISO standards, and so making sure we have the language to be able to articulate those requirements to make sure we have the appropriate equipment was important. And we got our funding in the middle of November 2014, so I was using this draft WHO guideline in designing the procurement for our initiative. But having that clarity on standards that is transparent and available was essential. I will say it was challenging because this evolved. We tracked, had a student look at this, and tracking some of the key items and commodities that are part of a PPE over time through that fall 2014 period. You see that some of the low-risk items were starting to be identified. The low-risk kits were emerging throughout the crisis. The high-risk kits were more commonly articulated, but they were not standard as to which combination of products were articulated in each of the standards. The CDC, WHO, UNICEF had different combinations of standards in their different releases of communications. And then within organizations like MSF, the contents changed over time as well. So it was a dynamic space, being able to have clarity on standards so we can enable various organizations to make sure they're procuring the appropriate equipment and not wasting scarce resources procuring equipment that won't be meeting the needs. Next is looking at manufacturing. So I was a little concerned, doing procurement, and I'm a professor. I have to make sure I don't fail here because I got to be able to teach my students and say I know how to do this. But I'd heard that UNICEF had a meeting just before we started our program, convening a lot of the different providers for equipment, PPE, MSF and others, with manufacturers to determine, I wouldn't say ration, but to allocate and determine how to match capacity with needs and the ability to deploy it. That's an important thing, and it's that kind of communication that I think is an important role. UNICEF did a good job convening the group, but I was worried that everything had been taken by the time we came around to do our procurement. But we worked with a distributor, and it's interesting because MIT doesn't have a medical school, so one of our distributors is a general industrial distributor, Grainger, and they were looking for suits that would be appropriate, and they found a company that hadn't been tapped by anybody yet because they don't usually serve the medical community. They usually provide industrial protective equipment for other uses like crime scene investigation. But by looking at the standards, the ASTM standards, checking to make sure it met the specs that WHO released, and then send that over to the Ministry of Health to work with their local people, CDC, WHO, to make sure that this suit would be appropriate, we were able to determine that this is a supplier we could use that hadn't been tapped yet. And so we found new supply sources that hadn't been convened at that meeting, which was an important part. I will say that one thing about this is the adoption was key. These suits look different than the DuPont ones. They're white instead of yellow. They have blue tape on the seams. Some people in the healthcare setting may be concerned that it is not high quality. And on that, we found out that also at the same time, New York City hospitals were also using the same provider for suits. And so we just made sure to communicate to the people on the ground in these facilities that this is the same suit that's being used in New York City. And that went a long way. I'll add another important thing. There was someone who worked for Clinton Health Access Initiative who had been supporting the Ministry of Health for a while, who took it upon herself to track supplies that Ministry of Health was receiving from various organizations, both the incoming pipeline and what they had in stock that had been donated. This ended up being very useful because our initial grant supported us working with 16 hospitals, but through saving some money in transportation and also by finding that MOH already had supply on the ground of some Tyvek suits, where there was concern, are these going to be appropriate? But we checked with the standards and again went through the process to make sure that what was sitting on the ground was appropriate to deploy to the hospitals. We were able to utilize stock that had been donated to the Ministry of Health that was sitting on the ground waiting to be deployed. So by having proper information and tracking, and this particular worker, Lauren Zinner, tracking this information, made that available, transparent and available for us to go and tap and utilize going forward to expand our operations. I will mention the importance of local procurement. We hired and trained a management team that completed 65 procurement orders locally in 60 days and accounted for $500,000 in funds, getting things like buckets and so forth that obviously don't make sense to ship internationally and are more appropriate in that setting. And then combining it with not only buckets and chlorine, but you have to look at the clean water supply. And I was thankful that the donor was able to give us flexibility to do things like enhance the access to the water, the wells, to make sure that the water is of good quality to provide chlorine. And finally, in transportation, lots of things come into play in terms of leading to shortages. We were able to charter a jet, cargo plane to ship the supplies. Customs was an important thing, to clear customs, and I was very thankful that the Liberian Ministry of Health identified someone to help work the paperwork to make sure that customs could be cleared quickly, having proper labels on our items. We worked with the logistics cluster to deploy items. Leveraging the logistics cluster was essential because they're out there procuring transportation services. We didn't have to, using their storage facilities and then finally delivering. And by working with partners, the government, with the logistics cluster, and staging this all ahead of time because we had that plan, we were able to take from our supplies from the plane that arrived on Monday and make our first delivery Friday morning, getting through that process very quickly by planning ahead and having relationships. So, results, we had a significant impact, but like I mentioned before, one of the lasting impacts is that we also helped to train staff that can continue to do this going forward. So involving that local staff in the process so that they have the capability to run this next time. And if you need to run a supply chain in Liberia in the future, give me a call because I know some good people. This has led to some work we've been doing with a student who was working with me at the time to understand what happened in the supply chains in that Ebola response. And we've done we did interviews and analyzed this to identify issues in the supply chain. And we're now combining this in a model that captures the supply chain dynamics, a system dynamics model, with an epidemiological model that was utilized in Liberia at the time, and seeing how those two models together can determine which supply chain levers might have the most impact on the trajectory of a disease. It's very nice that some of the modeling we use in supply chain aligns with the type of modeling that's used in epidemiology, and we're trying to merge those two together to identify models that could be used on an ongoing basis to track how a disease trajectory is affected by the supply chain. I'll close with a story from last year's hurricane season, and I'm actually going to be giving a talk this afternoon talking more about this work we did with FEMA. Our lab and several members from our team spent time with FEMA last fall helping them connect with the private sector to better provide response. And there's some stats on how big that hurricane season was, but I'll point to the bottom right here. This is the after-action report from FEMA that they've noted that this last year is maybe a point in which the experiences will help lead to improved approaches going forward and kind of a new way of thinking about how to respond. And I hope that will incorporate the private sector a lot more. And I'll mention one thing that may not be obvious in a health supply chain, that's fuel. So a lot of distributors and shippers in preparation for supporting Florida after Hurricane Irma positioned their trucks full of supplies in Valdosta, Georgia, out of harm's way, ready to roll after the disaster passed. But many of them held the trucks because they weren't sure that they could refuel. It's a long ways from Valdosta to Miami and back, and you have to refuel. And so if this truck stop if this tanker can't deliver fuel to the truck stop, the truck with those medical supplies may not roll into the affected area. So fuel is an enabler. And how do we enable these trucks, fuel tankers to move? Well, there were issues at the ports with lines taking up to 4 hours, waiting for access to the racks that allow the fuel to get into the tanker truck. The state of Florida provided escorts to make sure traffic wasn't an issue. That's one intervention that can play. In Puerto Rico, anticipating the issues that may arise with racks, FEMA helped to enable the ability to pump directly from a tanker barge into a truck. There are measures you can take to try to address this, but perhaps the best thing is to work with the private sector to understand the vulnerabilities. Another thing very directly related to the facilities in Puerto Rico was the fuel enables power generation through generators. Small homes and small businesses, but also warehouses and manufacturing facilities and health facilities. And you need fuel and you need parts to make sure that those generators keep working. They were designed for temporary use, not long-term use. And we held a roundtable based on our experiences, convening a lot of people, and highlighted some of the issues with this. And one of the interesting ones is fuel filters may have been the most important thing, because if you don't use a fuel filter in a generator, you have to do a lot more maintenance. And the maintenance was challenging to do. So the lack of fuel filters may cause there to be more issues with power than anything else. We have a summary report from that roundtable, and it's available publicly for you to access, that highlighted a few key things that we learned from last year. That a lot of the networks that we have are optimized and not very flexible. So we have to anticipate where bottlenecks might emerge in those very optimized, heavily optimized networks. The connection of people with these supply chains, and especially the role of drivers who are critical in moving supplies after a disaster, yet they also need to take care of their families and making sure that we understand the human need and of those critical employees, and then the cascading effects that can happen in supply chains. So that report highlights some of those things. And it's led to some work for us to look at a new approach, and we have a study now, FEMA sponsored with the National Academies, to look at how to better work with the private sector in restoring supply chains. And I'll mention fuel, for example. Understanding how this fuel supply chain works. How does fuel get into Florida? Most of the fuel refined in the Gulf area comes up through pipelines on the East Coast, comes by barges to Florida, understanding ahead of time. We could have known that fuel racks might be a bottleneck. We should have probably been tracking information very closely with those key nodes, understanding that ahead of time, sharing that information. The question is, it takes a lot of effort to communicate with lots of different parts of a supply chain, so we have to prioritize. How do we do that? We're exploring the use of sentinel surveillance. I was glad to hear the word surveillance mentioned this morning. We think that we can use scientific approaches, understanding how supply chains are structured and how flows work in normal times and after disasters, to identify the most important nodes in these networks with which we can establish trusted relationships, to share information. And we won't get 100% of what's going on, but if we can get 80% of what's happening at those really critical sentinel nodes, we can monitor the health of the supply chain and the ability for supply chains to deliver health products in a disaster. So that's what we're working on now. We are very much open to collaboration and suggestions on how to continue this work. We're excited about the opportunity of working with FEMA and the emergency management community in the US to develop these approaches. Thanks.
Thank you. Prashant?